What I think this work can and should lead to in the future is more explicit, targeted recommendations about who should do what. So, for example, we found that these patients had a number of issues related to sadness, worry, fears, and that makes very good sense. I can't imagine how scary it is to be diagnosed with acute leukemia and to be sort of thrown into the hospital quickly and suddenly and being told that you need to take this potentially life-threatening treatment that hopefully will help you and maybe even cure you, but we really don't know what's going to happen on a patient-by-patient basis. Who should be helping those patients with these kinds of psycho-oncology issues that we don't always do a good job of screening and addressing in practice? Should there be psychologists then who are part of the clinical team actively caring for these patients? Maybe, and that's probably something that we should test in the near future. Similarly, who should help us address these physical symptoms? Are they symptoms that we can just chalk up to treatment and say they're going to get better in a couple weeks and this is because of the treatment we gave them and maybe there's not much else we can do? I would say no, but that's been the status quo. We've been a bit defeatist about it, thinking high-dose chemotherapy makes people feel bad and it's just going to be difficult. I think patients deserve better and that we can do a better job of it. And so I would argue that these data basically tell us that we can and should incorporate concurrent palliative care as part of the blood cancer treatment paradigm for patients who have acute myeloid leukemia. There are many unmet needs there, and our colleagues in the palliative care realm who have particular expertise in addressing symptoms probably could help us do a better job of managing these patients.